All right, so I am going to transition us now into sort of the intro to NYMAC to hear from our NYMAC teams. We're going to hear from the co-leads of the teams from DC, Virginia, and New York. They're going to share with us the process and key findings of their respective teams with the barriers that motivated their projects and the project plans they have to improve access to genetic services in their jurisdictions. So we're going to start with our Virginia co-leads, Dana and Kristen. Bring them up. Dana Yarbrough is the Assistant Director of Virginia's University Center of Excellence in Developmental Disabilities located at Virginia Commonwealth University. Using her wisdom and experience as Brooke's mother, Dana sets a strategic vision for the Center for Family Involvement, Virginia's Family to Family Health Information Center, and the CDC's Learn the Signs Act Early project. Dana and her team at the Center for Family Involvement have been an incredible asset to NYMAC over the years. She serves on the NYMAC Advisory Committee and has been a critical support to NYMAC's efforts to increase family engagement in the network. So welcome, Dana. Kristen Cruz is the Public Health Nurse Supervisor for the Virginia Newborn Screening Program. She has a passion for CQI, education, and process improvements that have positively changed outcomes for the programs and families in Virginia. Kristen's incredible insights and perspectives about the current state of newborn screening and genetics in Virginia and her connections to other vital Virginia programs such as Title V and Children and Youth with Special Healthcare Needs and Care Connections for Children have been key to our efforts to integrate genetics into the systems that impact families in Virginia. So with that, I'm going to welcome Kristen and Dana.
Thank you. And are we using our own slides? I'm sorry, I just want to make sure.
Yeah, please.
Okay, awesome. Just wanted to make sure before I brought them up that I was using the right slides.
And thank you for the welcome.
So here's the blah, 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 a little bit about us. I don't have anything to disclose, Kristen?
I do not have anything to disclose either.
Great. So just a quick snapshot of our team in Virginia. We typically have almost everyone showing up at every meeting. We've had pretty good representation across all of these categories at every one of our meetings that we meet monthly. So just to give you a little tidbit into who we are, we want to do a quick poll right now about to see who knows something about the great Commonwealth of Virginia. So there's a couple answers. So you just you pick an answer for number 1, number 2, and number 3. And there might be a 4th question. Let me just see. Yes, 4th. So if you would just please do your selections.
Hey, we've got answers coming in. We've got about 100 people answered so far.
Okay, great.
Some people you can use the chat for phone a friend. Some of these are getting split. Some of these are strong leads, and some are there's some contention here. Or not contention.
I know which one that is.
Unfortunately, we do not have any prizes for the winners. Your reward is just being super knowledgeable about Virginia.
Could we show the results?
Yes, here they come.
So the answer to question number 1, the second oldest university in the United States is the College of William and Mary. So congrats to those. Some of you may have been thinking back to your history and how we landed in this country and what was happening in Europe at the time and in England and the King, and you might have grabbed that one. The first Thanksgiving, this is where we thought we might see some interesting answers. So the first Thanksgiving, now my family, we can trace it back to Mary Makepeace on the Mayflower. So I grew up outside of Plymouth and believed that the first Thanksgiving was held in Massachusetts. It was in fact held in Virginia. Virginia was settled in 1607 and had theirs, and Plymouth was not till 1620. So those of you who like me are a New Englander born, it was Virginia with the first Thanksgiving. Virginia state slogan, I believe folks did pretty well there. It's a kind of a strange slogan that we continue to use. And then the last one, I wish it was the largest lobster supplier. That was what I was hoping would be the answer, but it is the largest naval base. So those of you who are military may know that, or maybe you have been to Virginia Beach. Our naval base, it is the largest in the world. And we house lots of secretive stuff there that I can't talk about. But thank you for participating in the poll and learning a little bit more about Virginia. So Virginia is broken up into kind of 5 distinct health districts. A lot of our state agencies use this formatting. We have 134 technically counties and cities. They are broken into, some are counties or some are cities. They are broken into these 5 regions of the state. About 66% of Virginia is classified as rural. And so you can see the majority of the slides, 1, 4, and 3 are extremely rural. Parts of 2 are region 2 are rural. What is a kind of an interesting tidbit to me growing up reading the book Misty of Chincoteague is that we claimed for some reason part of the Eastern Shore that is not even connected to Virginia by land. There are like 14 islands. One of them is inhabited, Tangier, no cars, but there are people. And then the Eastern Shore is home to Chincoteague and the ponies. It's not very big and wide. And the only way to get there, if you don't go all the way down through Delaware and Maryland, is to go through a 17-mile tunnel and bridge that has about a $14 toll. And it is one of the 7th man-made wonders of the world. And then just a few other things about Virginia counties and health regions. I think it's important for our teamwork that we spend time looking at this and looking at really deep at the data, because there are some very big disparities. Southwest has service deserts. It's very, it takes a long time to go from one county to the next or city. Northern Virginia is like its own state. It is very distinct. It's densely populated, has over 135 languages spoken in our school systems. In fact, most of the school systems have about 30% of the children speak English as a primary language. When you get to the Eastern and the Virginia Beach, and you have to go through tunnels to get to Virginia Beach as well. And then you look at some of the other areas. And we have mixes of poverty throughout all of this. So we just wanted to kind of ground you a little bit in how much time our team spent really understanding the distinct areas of Virginia and what we thought were the barriers. So Kristen's going to pick up and talk to you a little bit about the needs that we identified in some of the solutions.
Thank you, Dana. So as Dana mentioned, Virginia has a lot of very diverse geography, from rural to urban to suburban to very high city or highly populated areas such as Northern Virginia. So when we talked about our needs as a group, some of the key features that are repeating items that came up were some pockets of areas are very undisturbed, and there are notable health inequities and disparities across and within all 5 regions. And we also have issues that have been described by multiple members of our team with getting Medicaid or even private insurance to cover services when crossing state lines. There are some disorders that need treatment that are not available currently in Virginia. The resources just aren't here, and crossing over to North Carolina, to Duke, or elsewhere to receive it causes some issues. Underinsurance for undocumented populations. Poverty level is increasing for military or school educators. Wait time for distance to service or barriers. There's a lack of resources in Virginia. Broadband access is a common theme. Healthcare providers, they need education about disabilities, referral sources, and the value of genetics. Things have changed since they were in medical school, and especially if they went to school in a different state. Things are different in Virginia than they may be elsewhere. And then hospitals and clinics are not typically built in rural areas or regions with high poverty. So we did discuss some of our possible solutions. Next slide, please. We came up with some proposals. And so when we looked at everything together, we came up with an idea of developing a genetics navigator toolkit. And this toolkit will be, again, this is a working proposal, so we're still in the early stages of it. But this will be a dynamic toolkit, and it's not seeking to replace the role of a genetic counselor. It's seeking to kind of bridge the gap from when the referral is needed for a family to move from the doctor's office, healthcare provider's office, to get them into the genetics office. So addressing some of those barriers. So we were looking at some of our existing services that are available. So there is interpreter training about genetics that's available at no cost because we have a lot of different languages in Virginia, where we would inventory existing resources currently available, include genetic education fact sheets in multiple languages. And then a big feature we're excited about is developing an educational module for these genetic navigators, or potentially an enduring webinar for training. And so what this would do, this would provide tools and resources for this genetics navigator as far as how to communicate with families. And our audience for this module or the toolkit, it isn't like a family who is just referred to genetics. This is going to be our social workers, our case managers, our nurses and doctors' offices. So more of like a clinical provider side. Not necessarily, we don't really see a lot of physicians doing it, but more of the supporting clinical staff. And creating a Virginia-specific website with toolkit and the resources. So that's one big piece that we have. And the other big piece was exploring a community education with a focus on underserved communities. So going to areas with underserved populations, talking to the colleges about potential careers in genetic counselors, providing education on genetics, working with trying to inspire and some interest in genetic counseling, because there's not a lot of resources available at this time.
And I would just add that we're also envisioning family organizations, the family to family. We already use family navigators, and they would may be interested in becoming a genetics navigator because of personal lived experience. And so we're looking at, as Kristen said, kind of a mixture of some families and some people that might be housed within Title V partner agencies or pediatrician or family practices to really have someone who has some access to this information. So they would go through the training, and the Department of Health would keep a list of who those people are each year. So we're pretty excited about that idea. So that is the end of ours.
Thank you so much, Dana and Kristen and the rest of the Virginia team. Thank you for giving all of them a shout out today. We're really excited about seeing this project come together. So now we are going to hear from our co-leads from New York, Sharon Chesna and Randy Zinberg. So Sharon Chesna is the Executive Director of Mothers and Babies Perinatal Network of South Central New York, a regional community-based health and human service agency focused on the reduction of infant mortality. Ms. Chesna has over 30 years experience in the field of perinatal health, which includes healthcare planning, program development and advocacy, and obstetrics and gynecology practice management. Sharon has really brought our attention to a lot of valuable resources and organizations to help support families in New York that NYMAC was previously unaware of, and her perspective on the needs around the perinatal period is a wonderful contribution. Randy Zinberg is an assistant professor in the Department of Genetics and Genomic Sciences and the director of the graduate program in genetic counseling at the Icahn School of Medicine at Mount Sinai. For over 30 years, Ms. Zinberg has provided genetic counseling services to individuals and families referred for genetic counseling issues from preconception to adulthood. Currently, her genetic counseling practice includes the provision of pre and post counseling of variant and whole genome sequencing findings, as well as the design and implementation of clinical genomics related studies. Randy brings to NYMAC the very important perspective of our genetics training programs and helps us consider and participate in the future generations of genetics professionals and the new perspectives that they bring. So welcome to Sharon and Randy.
Thank you. So I'm going to start. I'm Randy. These are our disclosures, and we can move on from that. Okay, so the New York team had stakeholders from genetics professionals, genetic counselors, geneticists, primary care providers, public health experts, and most importantly, families and patients.
So a little bit about New York. I don't think we are quite as creative as Virginia with respect to a little quiz for you, but New York is the fourth most populous state in the country. And as you can see here, about 43% of our population for the state overall, 8 million people reside in New York City. Oftentimes, if people aren't terribly familiar with the state of New York, they tend to think about New York City as New York. The reality is, we really probably look at New York as almost three different areas. You can look at the upstate New York area, which is pretty much everything above the New York City and Long Island's area. In the upstate New York area, we have just a little over 6 million in total population, but an extraordinarily large geographic area. And then Long Island, which is often lumped with New York City, actually is a very densely populated community or region of their own. And the population on Long Island is just about 7.5 million. So when you can put the two of them together and think New York City and Long Island, and we refer to it oftentimes as downstate, it is where a large concentration of the population is. So I think we'll move from there. And you can see, I just wanted to point out through the map here that when you look at the density, which is your darkest reds, you can look down at the bottom right and you'll see, of course, that's the Long Island and New York City area. If you move right up from there, you're going to find the Albany area. Just above that, moving to the left, you're seeing the Syracuse or Onondaga County area, which again, that's the population of the Syracuse. Continuing left, you have Rochester, and then to the far left is Buffalo. And those are our largest metropolitan areas. The interesting piece is that when you look at the fact that New York has 31% of the NYMAC population, what does that mean for us? So 25% of the genetic counselors, and you can see through the slides here, where those all lay out amongst our region. But with our geneticists, we have a very high, percentage there. 27% there. And if you look again at where our population in the region is, and again, in some areas that really means that in our more metropolitan areas is where we have the service providers, and that large area of upstate New York often, shows where there's a gap. When we're looking at the information on the New York region, we do need to look at our non-white population, and because it has significance related to higher incidences of disabilities and such. So when we look at our Black population, you can see that it's predominantly the counties that are New York City, which is actually in there, and the Hudson Valley, which drops right below that. And as I mentioned before, you can follow it with our metropolitan areas, Buffalo, Rochester, Syracuse, and then Albany, which is Albany County. One of the most particular areas that we look at across New York overall, Bronx County, which does have the highest rate of Black population, Hispanic or Latino, is very significant. We see a lot of poor birth outcomes and a lot of health issues in the Bronx area. I'm sorry. And so I think then this is just, again, a visual to show you again where the density is of our Black and Latino population. When we look at what are the children with special health care needs, approximately 656,000 children up to the age of 17 have one or more special health care needs. So this is significant. And of course, we rely a lot on our county health departments to begin the process with the children with special health care needs and getting them into the appropriate services. Key to this is, and you can see on the second bullet, that almost half of those children live in households with income below 200% of the federal poverty level. What we're really talking about here is about 325,000 children. So that is significant, that where families really don't have the resources. And I think, as others have indicated, making sure they have access to health insurance in addition to the healthcare really becomes critical. The mapping that's highlighted in the last bullet here, includes a program such as Parent to Parent and the Leadership, Education, and Neurodevelopmental Disabilities, where they're really reaching out to parents and caregivers to identify what are their challenges. And this is actually where we're going to move right into the surveys that we did. As Randy mentioned, with our team took a lot of time to identify families and providers throughout the state so that we could really get some good geographic representation to really understand what the different difficulties were in different areas of the state. Randy?
Yep. So looking at those provider and parent interviews, there were a few of them, and using a standard interview guide. And what we wanted to know was, what are some of the biggest barriers to patients accessing the genetic services that they need, given what we just said? So we have this very large state with areas of dense population where there may be more providers, and then areas of the state with really very, very little. So we wanted to know barriers, maybe some strategies, start to think about education and models of delivery. And next slide, Sharon.
Yep.
And that helped us identify some main barriers and themes. So one of them, as we heard before with Virginia, was distance. So, I'm used to the downtown, the downstate area of New York, where we can travel by subway and bus. But there's areas of the state where they may travel miles, hours to get to a genetics appointment. Again, we discussed the workforce, and you also heard from Virginia's traveling out of state can be very problematic with state insurance. And then we said, oh, well, there's telehealth. But, as we've seen, telehealth can be, really terrific, but there are issues that come with that. Broadband, you can be in a home where there's no privacy, cell phone usage, and of course, meeting the needs of our constituents who do not speak English. Education. Education is always a predominant theme. We need both education for our families as well as our healthcare providers. Within that, we started to hear some discussion about the idea of transition to adult care from our pediatric population for our chronic diseases, how to navigate into the adult care sphere, developmental surveillance and referrals, about appropriate referrals, when to recognize referrals, and how to navigate genetic testing. And our families also recognizing when do I need to see a genetics provider, how do I navigate the health systems, insurance, and again, that theme of transitioning a child to adult care. And underserved communities. We are diversity rich in our state, and that does come with it some issues, as you just heard. And how do we identify the needs of our underserved communities and provide them what they need? So our group, taking all of these themes together, discuss the ideas of distance and education and how to meet the needs of our underserved communities. And our team really felt that for the purposes of our project, we wanted to really focus on the education for families. And that's why that is highlighted. And so our consensus was, what can we do to help our families identify the needs below? And again, that impacts also our providers need to understand some of these issues as well. So how can we kind of get both?
So with all of that, we were a little conflicted because we really wanted to reach out and provide the information to families. And so we began the development of, this piece that you see on the side here, identifying the areas that would most be likely for families. But I say conflicted because we also wanted to make sure that this is information that can be shared with providers, who in turn are oftentimes a referral source for families. One of the other pieces that we looked at, if you look at our document that we've been creating, is, the difference between helping families let me just see if I can go back. Helping families understand all the different types of things that they need in order to get the services they need for their child or other family member. And then also, do they get to a genetic provider? And actually in our breakout a little bit earlier, one of the colleagues in our breakout room, Alissa, was commenting on, with all of the providers oftentimes that a family needs to see for that person who has, that special healthcare need, the question often says, why do I need to see a geneticist in addition to all of these other providers? So, we were trying to blend why it's important for them to see a genetic provider, as well as then perhaps lead them through what are the resources that are available to them to get what they need. And so you can see our questions with respect to, one, does insurance cover it? Where do I go for an appointment? How does it change as my child ages? And that was a very significant discussion that we had about this. So our intention here was to utilize both social media and print media, as well as getting an email distribution out for these services, and always referring them back to our website for that. So our goals are to, build the New York page, to translate the materials into other languages, and we're beginning to look at the resources for that. And then try to make sure that this media campaign, if you will, really reaches families that are not already in the system. So we do intend to utilize some of the resources that we have across the state, which are, a family-to-family, parent-to-parent programs. We have a compendium or our Association of Perinatal Networks. We actually have 14 perinatal networks located throughout the state that can do this through their community-based work. Obviously, our WIC programs, and there is a large home visiting collaborative that includes a variety of the different types of home visiting programs that hopefully can help get the word out, because they're really serving, our maternal and young child population. So the next strategies we had would perhaps be Facebook, and then perhaps really using this to reach our providers by utilizing LinkedIn.
And though the slide may have had, a lot of what we're thinking on it, the idea is also to help simplify the process.
Mm-hmm. So as I think DC also indicated, we've been really working hard on this and come together. And so what we've now done is mapped out our timeline. What you saw on the previous slide is really sort of the, I think, 4th or 5th edition of our draft. And that's where we have been with the document that you've seen. And we hope to wrap that up by, next month. And then, really define our marketing plan over the summer months, and then begin testing, the resources to get that feedback, and then obviously do what modifications would be recommended based on that testing. And hopefully we'll be able to launch that website, as you can see here, in August, fully put together our social media plan by the early fall. And I would also say that we're very fortunate, because on our team, we have an individual, it's a parent who actually is in media and has provided a number of wonderful suggestions as to how we might actually, utilize the resources they have to sort of geo-focus our messages. And then depending on, where we go, we recognize that the budget that we have is limited. And so a print production to manage to really reach across our state is extraordinarily challenging, hoping perhaps to partner with others for some of that, and then begin our evaluation at the same time as we move that out. So our evaluation plan, of course, which is a very important part of the whole piece, is to really look at, the various ways in which the various whether social media or other, and measure the traffic to those, how much we can reach and what the, the clicks and the links are. So we're looking at all of those metrics for the traffic that will come to these. We're relying on, again, our partners to help us with some of the email distribution and maybe perhaps a report back to us about how they've been able to disseminate the materials or to connect the social media sites to various things. So that's sort of where we're at right now. And again, we'll probably be tweaking along the way, but we're really enthusiastic about moving forward. And we think that, the predominant, media plan for this is really the most effective strategy for us. So I think we're finished with that. And I don't know, Alissa, are we leaving questions to the end?
Yeah, we are.
Okay.
So thank you so
very
much, Randy and Sharon. We're definitely really all looking forward to seeing that New York project come together and super optimistic about the impact we can have there. So next up, I'd like to welcome Barbara Harrison and Dr. Natasha Scher. So Barbara Harrison is a certified genetic counselor and provides genetic counseling services at Howard University Hospital, primarily in prenatal genetics. She's an assistant professor and teaches graduate students, medical students, and medical residents in various specialties in the areas of genetics, genetic testing, genetic counseling, and ethics. In addition to these duties, she's the assistant director for community outreach and education for the Howard University Center for Sickle Cell Disease. Barbara has worked with NYMAC for many years on various projects and is currently collaborating with us both on the DC team as well as leading the Golden Project, which provides mentorship throughout the genetic counseling graduate school application process with a goal of increasing the awareness of genetic counseling among Black students, primarily at historically Black colleges and universities. Dr. Natasha Scher is an associate professor of George Washington, a medical geneticist at the Rare Disease Institute at Children's National, and the lead of telemedicine for the Division of Genetics and Metabolism. Her current focus is on improving clinical care models for rare disease in order to ease patient burden through innovation, such as apps, virtual education, and telemedicine programs, in close collaboration with the Children's Research Center for Innovation and Telemedicine divisions. Dr. Scher has also worked with NYMAC for many years and across various jobs. She serves on the NYMAC Advisory Committee, has been a close collaborator with NYMAC around the outstanding work being done in pediatric telegenetics at Children's National. Both Barbara and Dr. Scher contributed greatly to a recent NYMAC video project that was shot in DC and captured both family and provider testimonials, which you will get to see several different pieces of today. So welcome to Barbara and Dr. Scher.
Thank you so much. I am going to share my screen. And I can just get some. And can I be heard okay? And you can see my slides?
Yep.
Yes.
Excellent. All right. So good morning, everyone. Thank you so much for joining us today. For those who it's helpful, I have a white background. I'm wearing a black shirt, and just happy to be here to present and talk to you a little bit about our experiences in DC. So you've already been introduced to myself and Dr. Scher, which I've certainly had the pleasure working with over these past few months. We were just sharing how peaceful and lovely our relationship is. We really just work so fun. It has been great for us to be together. So we have no financial disclosures. And today, similar to the other groups, we're just going to provide some background on DC, speak a little bit about our team, discuss some of the needs that we identified through the interviews that were done, and then what our project is and where we're going to go from here. So, similar to the other states, we identified a mix of genetic counselors, geneticists, family advocates, and individuals and parents as well to be part of our team in DC. And so we certainly want to thank them for their efforts, for their time in helping us shape what has now become our final project. And you'll learn more about our interviewees later when Dr. Scher talks. All right, so just a little bit about DC. Of course, we are a district. We are actively pursuing our efforts to become a state. You may have heard some of that, very quite recently. But for the time being, we are a district, and of course, DC is very diverse with many different cultures and ethnicities. We're the 20th most populated city in the United States, and about 10% of families in the district speak Spanish as their primary language. But similar to the other urban regions, there certainly are a mix of many different languages and ethnicities that are represented. Now, DC is divided in two major ways. So one is we're divided into quadrants. So if you've been anywhere around DC, you've heard people talk about Northwest and Northeast. So those quadrants divide DC starting at the Capitol. So the Capitol building is around here. And so from here, lines are drawn that separate the district. But what's really more important when we start talking about health and certainly around demographic regions and so forth is the wards, the 8 wards that DC is divided into. And so you see them numbered here. And these wards are really more informative as far as thinking about issues around poverty, about income discrepancies, and also in thinking about where the majority of children live. So wards 7 and 8, as you can see here, along the southern side of the district are separated from the rest of the district through this black line here, which is really symbolizing where the Anacostia River is. And so often when we talk about wards 7 and 8, we talk about these wards that are east of the river. But this is important because these 2 wards have the largest number of young children and also have the lowest median and family incomes in the district, and also represent the majority of families who are African American, as well as some other key ethnicities. So that's one thing to keep in mind. Now, when we think about the health services in the district, you can see I've pointed out our major hospitals here, of which we have 7 hospitals and medical systems in the district, 5 of which are birthing hospitals. Now, 4 of the hospitals have level 1 trauma centers. Several have neonatal units, neonatal service units. But what's really, what I really want to point out here is that these hospitals are really aggregated in our northwest quadrant, and not very close to where the people who need it most are located. So again, if those individuals are located in Ward 7 and 8, we're really seeing these hospitals are aggregated in other areas of the city. And so I put here as well our metro map. And if you've been to DC, our metro is very clean and nice and great to ride. But unfortunately, it is not similar to subway systems in other cities or urban regions where you can really reach a lot of part of the cities through the metro. Instead, the metro is kind of sparse. And so even if you take the metro somewhere, you often have to take a shuttle or a bus or something else to really get to where you're trying to go. And that is true, unfortunately, for the hospitals as well. So even though we don't have the same hours of travel as far as, geographic distance in DC, the time that it still takes for families to access good medical care often still does reach into those hours because of the time you have to take going from, a metro to a bus to maybe another metro to a taxi to get to where you need to go. And so that can certainly provide some challenges. Now, I alluded to this a bit before, but again, wards 7 and 8 are not only where the majority of children live, but also where we see some significant disparities in income. And so, whereas the district, which is really home to not only Native Washingtonians, but individuals from the military and folks that come here for government and for other areas of work, the median household income is actually quite high at $80,000. but we certainly acknowledge that a good portion of that population lives below the poverty line. And the bottom point, I think, is particularly striking, but I think was even striking to the team as we, pulled out these numbers, which is that the income for the white population in DC is so significantly higher than the median outcome for those of Hispanic or African-American background. And so when we thought about where the needs were and who we needed to try to reach out to, we certainly were keeping these disparities in mind. And coupled with that, of course, is insurance coverage, where you can see here that about a third of the of our DC population is covered through Medicare and Medicaid. Another, about 60% are privately insured. And although the majority of children are covered through insurance in DC, about 44% of them are covered by public insurance. So we were deliberate in our efforts to reach out to the providers of healthcare for those children, for that Medicaid population, because we knew that that was where we need to focus our efforts as far as wanting to impact and really increase the care that was delivered to children in the district. And so just to emphasize a few more points, about 24% of children under 6 do receive developmental screening, but you can see there's quite a few that do not. About 20% reported that their child has special health care needs. And I think was mentioned before, even with some of the other states, this issue around transition is also a problem in the district. So with that, I'm going to pass it over to my colleague, Dr. Sher.
Thank you so much. So Barbara, it really has been a pleasure to work with such an amazing advocate for patients and families. Thank you. And with the NYMAC team in taking a step back and thinking about these needs assessment interviews and my own personal career and story. For over the first decade in clinical medicine, we really focused on helping one patient at a time, but I don't remember ever the administrators or people asking us or our patients, what can we do to make the entire system better? And we've seen, and NYMAC is really leading this paradigm shift where we're reaching out to people, as Barbara mentioned, and really targeting communities where we see need for intervention and asking people. And like Dr. Kim said in his first presentation, the first step really was just listening, hearing people's stories. And then the second step was systematically taking those stories, taking the feedback into account and creating a basic list. Because without that systematic review, we couldn't think of ways to address each of the challenges. So we reached out to our team, we reached out to our patients, and we asked whoever could help us and share their feedback, share their stories. And so we chose parents, we chose pediatricians in the areas where, as Barbara had mentioned, we saw disparity, public health administrators, and we did these interviews. And to give an example of a parent interview, I know that Tech was ready to help us with just a quick snippet.
Once we had the diagnosis, there were several things that followed from that. One is we could talk about with the team about prognosis, certainly, but also about what will his life look like. Having the sense for like what we're going to do long term in that sense was really, really big. And that only comes from having the diagnosis, because you don't know what his life is going to look like otherwise.
So it was just hearing from families about their positive experiences, but also what prevented that step of getting the diagnosis and what barriers were there. Next slide, please. I don't know. Yeah. And so some of the feedback we got, we took one and Pat and Alissa, thank you so much for all the work you did here, really listening to the interviews, spending hours listening to the recordings and taking out some of the key points, including the concern about timely appointments from the pediatricians, making sure the parent understands why we were referring their child, the importance of telling the community, why do you go to genetics? The concern about the financial things, the confusion and stress when bills come, the importance of incorporating early intervention and having early intervention as an outlet, and somebody to say, oh, look, your child has delays, what about genetics? Trying to get the population to have a better understanding of why go to genetics, and getting people to that first appointment seemed to be a major concern. Next slide, please. So we also collected kind of quotes and experts. So one of the pediatricians said, I'm not very good at giving out brochures. I don't think people are very good at reading them. Well, that's news to us because I spent my first decade in clinical medicine reading those brochures. I try to identify information based on the condition, making sure that the information is from a reputable site, realizing the shift to, like we're saying in this meeting, to Twitter, to Instagram, to all the social media, and realizing that's where people are going to get their links and their information. Videos are the best, maybe in the waiting room. So the shift to using videos, the combination of things that would include videos, short social media. Again, the emphasis from people on getting the word out through these new mediums, not so new for some people, newer for me. I think something defining genetic counseling, the goal of being referred, the services. So next slide, please. We took this list, and together as the DC entire group and with Alissa, Pat, Michelle's help, we really made kind of what I consider the grocery list, the difference between going to your random grocery store and throwing in everything into the cart and really pre-planning, thinking through how do we categorize all of this so that we can address it. So we thought about the education of the providers that refer families to genetics. And we said that PCPs may not have experience with some of the rare conditions. So maybe we need to make it easier to recognize who needs to be referred, to show those red flags, that those children, that 20 or so % with developmental delay may not be flagged right away, to really get across the impact, the reason for the diagnosis by sharing those stories to help with ordering needed genetic tests, and address some of the concerns about finances, costs, coverage, education on that, and help with that. And then educating the families about the value, relevance of genetics, competing priorities in families. When you look at developmental referrals, they give families about 8 things to do, but they don't have an executive assistant. Many of our families, it might be a 1-parent household. They don't have 10 people to help them while they're manning 4 or 5 children and trying to get to their medical appointments without, like Barbara said, the perfect metro system. The lack of trust. I think that once you get to that first appointment and establish the connection and listen to families, that's a recurrent theme, let them share their story, they will trust you. Then they'll ask you for advice, but you have to listen first and get people to that first connection and meeting. The confusion about how to make the appointment and the confusion about insurance coverage and payments. So next slide. And as we've been saying, and Barbara did a really good job of showing the disparities in access to genetics across race, income, geography, it's really only in the last 2 years that I've seen so many more honest conversations about the disparity, the undocumented families who face unique challenges and fear, the particular lack of referrals for children with developmental delay, that fact that you can see a different referral distribution depending on the ward or the area or geography where they live. The lack of trust in the system, the travel to genetics that can be challenging, traffic, public transport, providing people with more assistance, travel funds. We've had models where we use travel funds as clinicians. We have a travel fund and we can just, our patient needs transportation at 2 o'clock in the morning and we can just use it. That is life-saving, or for patients having that same access. Some concerns about rapport and telehealth and education needed about the value of the genetics visit. Next slide, please. So after we got together with the entire team, we really realized that we couldn't address everything on the list. That will take a very long time, but we saw the recurring theme of education, awareness. That was a big thing in the word cloud earlier, and people are recognizing that. And then we saw from all the feedback how important it was to utilize social media. And so our hope is to develop more videos from DC families on social media, prompts to explain their experiences with genetic services. So it's really community aligned, maybe a contest with prizes, incorporating high school students. We notice teenagers are constantly helping their families, especially with language barriers, get on Zoom, and they're actually serving sometimes before we can get the Zoom translator on as translators. They're telling their families to refer their siblings, to compile videos into a single educational video that can be used for families and providers. And so we wanted to, and if media could help me out, share another example that tells us why we're doing this for families, the power of the family voice and sharing their stories.
Bueno, Yamila es una niña muy tierna y muy inspiradora por su fortaleza, por su determinación cada día de su vida. Eso es lo que más admiro de mi hija. Es realmente una aventura muy larga, con muchas tristezas en el camino, pero con mucha superación. No me imaginé tenerla tantos años en la vida.
This is one of our patients with Pompe syndrome, and by telling her story about genetics access and how it improved her life, we feel that that can make an impact and encourage other families who likewise may speak different languages and are brilliant and such good advocates for their children, but their voices can be heard by everybody with the help of translation. And so next, I think we have to go back to the slide deck, but if not summary, we wanted to really partner with the community to thank everybody, particularly Pat, Alissa, Michelle, Barbara, the rest of our DC committee, and the patients and families we serve for coming together and leading us into these projects that can help us address these barriers, one barrier at a time in a systematic way. And the joy in working on this project is really getting to listen to people and share feedback and address it. Thank you.
Perfect. Thank you so much, Barbara and Dr. Schur and the whole DC team. We're so excited to now have an opportunity to share with you the full 6-minute video with you that NYMAC recently created in the DC area. Again, this is not the DC team project, but it has the goals of the video project are very similar to the goals of the DC project. And I think you'll all enjoy this sneak peek.
So you've been referred to a genetics doctor. Why is it worth going? You're about to meet 3 families who asked that very same question.
Hi, I'm Ava. I'm 3 years old.
We weren't expecting any complications. We were kind of going into it ready for this picture-perfect storybook delivery. And
shortly after her birth, she suffered a respiratory issue that required intervention by the pediatrician that was at the hospital.
So we didn't know what was wrong. Later that evening, we found out that she had multiple heart defects.
This is difficult for us to talk about, especially Alice. She doesn't like to discuss it. It was absolute quiet in the OR as Leo came out. He didn't make any noise. None of the staff said anything. And Alice said, "What's wrong? Why isn't my baby crying?"
Little Leo wasn't getting air through his mouth, and a doctor had to intubate him. The next day, a geneticist diagnosed him with Treacher-Collins syndrome. When Yamila was born 17 years ago in Peru, the doctor said she had an enlarged heart, possibly Pompe syndrome, and there was nothing they could do.
It was terrible, of course, for parents, knowing that your kid has a disease that has no cure. So there are no hope, and the doctor says that you need to go home and wait. But as a parent, I said that we need to try. We need to try and look for some cures.
And what he found was a clinical trial and a whole team of doctors.
It's like a small family and a team that wants to help not only the patient, but also the family.
A geneticist is a doctor who sees kids and adults with rare and/or complicated medical conditions.
Some families see medical geneticists right at birth. Maybe there's an abnormality or a concern about the newborn screen, which screens for certain metabolic and other conditions. Other families have children that seem to be developing fine, and then something might go wrong where they realize that their child has autism or a child develops seizures or other medical problems, and they're looking for answers later.
And sometimes the family notices delays in their child's development. That's another good reason to see a geneticist.
I mean, in general, it involves a physical exam. That's what happens when you go to see most providers, reviewing the history, updating it. We spend more time on the family history because any testing we may consider is done within that context.
One of the things that we can do now that we couldn't do even a couple of years ago is that we can do a lot of things by cheek swab. So people who are afraid of needles now have another option where they just rub a Q-tip around the inside of their mouth, and we can get their genetic information that way. Some things that we look for the amount of DNA that they have. If they have any extra or missing DNA, we can look for spelling changes in DNA that might cause a syndrome that would explain a person's medical concerns.
And then you have the genetic counselor who's able to really translate, I always think, kind of translate that information in a way that the family can understand.
In most cases, having an answer, a name for a child's medical condition is really important. For example, when patients have an answer, that means that they can reach out to families across the world who may have children with the same exact rare condition.
Go to one of the Facebook groups, the parent support groups versus Google, because that's where you get the real information.
We went to the Treacher-Collins syndrome Facebook page. If you ask a question, they will respond with 75% what a cute little kid and 25% okay, this is what you need to know. This is what our experience was. And so kind of practical troubleshooting, which was amazing and very, very valuable.
Not all families realize the value of a genetics appointment, the benefit of a possible diagnosis, the connections with other families, and they don't keep their genetics appointment.
People may think that, oh, well, I can't change my genes right now. Why bother go to see genetics? Some people have a hard time getting to us. Either they don't have transportation. I have some families who don't like driving in the city, and so they won't come see me because they would have to drive in the city. For families like that, we offer telemedicine, and that can be a great way to get at least a first visit done. And we can assess whether or not we need to do a second visit, to do an in-person visit.
So if a parent is on the fence about coming to genetics, I would absolutely advocate for them to at least go to the visit and share this information about their child, because I think that genetics professionals really have a unique perspective. We take all of these little pieces and we try to say, is there one underlying explanation for all of this?
El mejor consejo que le daría a un padre que vaya a visitar a un médico, a un genetista, y si hay que buscar muchos para tener opiniones diferentes, lo haría una y mil veces.
It's intimidating to know that you might come out of meeting with a geneticist with a diagnosis that you certainly never hoped for your child. But I think knowledge is power, and you only have that knowledge if you go through the process that could be painful, but at the end of the day, arms you with the knowledge to do what's best for your child.
Okay. So thank you to all the people who worked so hard to make that video happen, most especially to the families who shared their stories with us. I already see people commenting in the chat about getting access to the video. We'll be making it available pretty soon on the NYMAC website. It's also being translated right now, so it'll be available soon. We really do hope it'll help families who are new to the system feel a little bit more prepared about what to expect when they take that leap to go to their first appointment. So with that, I want to give a big thanks to the great panel and to all of you for your participation, and a thank you to our other state team members and interviewees that we also have on the call today. We look forward to working with many more of you on our other NYMAC teams in the years to come. Please reach out to NYMAC and learn more and get involved. I'm going to pass it back to Erica now to move us ahead.